Hello everyone, and thank you for joining us today. I'd like to welcome you to today's event. All attendee phone lines are in listen-only mode. During the session, we'll have a question and answer session, and we'll provide directions using the phone at that time. During the event, you may submit questions or comments using the chat pod to the right of your webinar screen. In addition, you can download today's presentation and other materials using the Files pod located in the lower right of your screen. As always, please type in your questions throughout the session. We'll get to as many as we can, and for those that we aren't able to answer, we'll be providing additional information on CPC Plus Connect. And now it's my pleasure to introduce your moderator for today, Stephanie Plum-Maxwell.
Thank you, Nikki, and welcome everyone to today's Practice in Action. We will focus on behavioral health integration and understanding the primary care behaviorist model. Joining me today is Megan Post with Springfield Family Physicians and Center for Family Development as our practice panelist, and Jennifer Boaz with the CPC Plus National Learning Team, who will engage in and monitor our chat today. During today's session, we will review key elements of the primary care behaviorist model and critical considerations when implementing. Next, Megan will share their experience with choosing and implementing this model, followed by a live question and answer session. And finally, we will ask you to complete a brief survey and then wrap up today's session. With that, let's get started. Last week's Practices in Action focused on the care management model for patients with mental illness options. Today, we will focus on the primary care behaviorist model option. This table highlights the key differences between the two BHI implementation options. This resource is available for download under the PIA Files pod to allow for further review and consideration. The key highlighted differences around the behaviorist scope and role are outlined here. The primary care behaviorist screens, assesses, diagnoses, treats, and monitors behavioral, mental, and substance use conditions as well as social issues. The behaviorist utilizes evidence-based therapeutic interventions modified for primary care, such as brief therapy and crisis management. He or she engages in independent decision-making for diagnosis and treatment. As we continue from the previous slide, the primary care behaviorist is generally a master's level or PhD trained behavioral health provider, typically with credentials to independently diagnose certain behavioral health conditions. He or she engages patients in person and on the phone and provides consultation to the care team. Telepsychiatry can be incorporated as well. The behaviorist tracks and monitors patients as part of overarching care. Targeted treatment sessions are typically time limited, but can be adjusted based on the needs of the highest risk tiered patients. Knowing the key differences between the two models allows you to begin to assess your practice to help decide which model is right for you. A great place to start is to assess your patient population to determine the overarching needs of your unique patients. Your patient population assessment will identify common behavioral and mental health conditions as well as chronic health diagnoses you see most in your practice. It is also helpful to understand the severity of these conditions as you choose which model to implement. You may be administering assessments such as the PHQ-9 to assess depression or the GAD-7 to assess anxiety. Additionally, what are the most prevalent co-occurring behavioral and medical conditions? Which ones do your practitioners desire the most assistance? You may have a sense of what conditions are most prevalent in your practice, but reviewing data available in your EHR and from your payers can provide validation. Shortly, our practice panelists will share what they learned from their patient population assessment. Assessing resources and competencies allows you to better plan for successful implementation of the primary care behaviorist model. Important considerations include space to co-locate a behaviorist at your practice and a schedule to have him or her available for warm handoffs. Identifying targeted screenings and treatment modalities based on your practice's patient population assessment and needs. What are the opportunities to integrate these into existing workflows? How does everyone on the care team utilize the electronic health record to record and retrieve relevant information and document care? How will patient and treatment goals be documented and co-managed? Assessing the collective competencies of your existing care team will also help you to identify knowledge and skill training opportunities when considering the primary care behaviorist model. Our practice panelists will also share how their practice acknowledged behavioral health integration attempts to merge two different cultures. Understanding and developing a culture that supports BHI is critical to fully integrating a behaviorist into primary care. Encouraging a multidisciplinary team approach to care delivery through care team meetings, huddles, and patient co-management sets the stage for successful behavioral health integration. There are opportunities for bidirectional knowledge sharing for both the medical and mental behavioral needs of your patients. When identifying the right fit, behaviorist time and scheduling, practitioner needs and expectations, willingness to work as a multidisciplinary care team member, and willingness to support training and development are important considerations when trying to find the right behaviorist for your practice. The considerations we just reviewed, along with several others, are listed in the Primary Care Behaviorist Model Worksheet example you see here. This tool is available in the Files pod for download. It is also available in the CPC Plus Connect library. This worksheet lists many of the key areas to evaluate in your practice as you begin to implement this behavioral health model. And at this time, I would like to officially welcome Megan Post with Springfield Family Physicians and Center for Family Development. Today, she will share with us why they chose the primary care behaviorist model and tips they learned for successful model integration. Megan, welcome, and would you mind introducing yourself and sharing some demographic details about Springfield Family Physicians?
Thanks, Stephanie, and hi, everybody. I'm Megan, and like Stephanie said, I'm with Springfield Family Physicians, and we are located in Springfield, Oregon. We have currently 14,250 patients that are active in our clinic, and we have 11 providers, and we also have 24 medical assistants, and then we have an additional about 24, 25 support staff in addition to those medical assistants. And we use eClinicalWorks for our electronic health record, and we are on track 2.
Very good. Thank you for that introduction, Megan. So there are many considerations when choosing a model for behavioral health integration. What considerations did you and your team make around your patient population?
So, you know, our model has been really kind of an evolving model. We sort of started out using the PHQ-9 and the SBIRT as our primary screening tools. And through the use of those, the providers at Springfield Family Physicians really began to notice that there was a big need to have behavioral health providers available. And so we previously used just a co-located model of having behavioral health provider in the clinic who was mostly available for follow-up visits with patients who had anxiety or depression or substance use issues. And over time, what we realized was that we really needed the behavioral health provider to be more integrated into the primary care clinic rather than just having the co-located model. And so really over time, we have built up a bigger program that includes 2 fully integrated behavioral health providers who work within eClinicalWorks. And what we were able to find was that patients just had much more access to behavioral health services within the clinic, and that the communication between the behavioral health providers and the primary care providers was much smoother. And we also had, in sort of moving through the changes of our model, we had a lot of support from our coordinated care organization. We participated in a learning collaborative with them. And we also had support from the Oregon Health Authority in projects that we participated with them, and as well as in research projects with different universities. So it's really been an evolving process, but I think where we are now with the behaviorist model is really kind of the most successful place that we've been.
Well, that's really exciting. So it sounds like once your team chose your behavioral health integration model, they went to work pretty quickly. Can you share with us some of the tips and lessons learned along the way that are key to successful model integration?
Yeah, so a few of the things that we've found to be really helpful are schedule and space considerations. We have our behavioral health providers located in a central spot so that the primary care providers always know where to find those behaviorists. So they're located in one central spot, and since we have 2, we have them alternating their schedules. So one is always available for warm handoffs, same-day appointments, and also for crisis calls. And then the other person is available for follow-up visits during that same time. And so they switch throughout the day so that they both have an opportunity to do the warm handoffs and same-day appointments, and then they also both have the opportunity to do follow-up visits. One of the other things that we've found to be really helpful is just being able to collaborate in a structured way. So we have team meetings that happen every other week in the clinic with the primary care providers and the behavioral health providers. And so they can talk about some of the difficult patients. And then we also have the behavioral health providers typically go around each morning and check in with the providers to see what patients are coming in for the day, what kinds of plans they might have for doing warm handoffs, and just sort of making sure everybody's on the same page. As I mentioned earlier, we found that using the same electronic health record has been really helpful. It allows all the providers to be able to see everybody's notes and kind of get an idea of what patients are working on and what goals they're setting, and everybody can support that plan. And the last thing that we learned is the importance of what kinds of positions to have. So we have always maintained having a person in the clinic who's the coordinator, and she does a lot of the scheduling for behavioral health. She does some case management and just kind of tracking referrals for patients. In case we refer them out of the clinic, she can always follow up and make sure that they were able to access behavioral health outside of the clinic as well. And we've found that having psychologists and licensed clinical social workers works best in terms of billing for insurances. And then lastly, we have a community support specialist who goes out into the community with patients who may have a hard time following through on appointments in other places. She can help people with finding housing or jobs or, whatever kinds of basic needs people have. She helps with that. And then the other thing that we have maintained is we do keep co-located therapists in the clinic as well, just to make sure that some of those people with more significant mental health needs can be tracked more closely, because we did find that when we were referring patients out to specialty behavioral health, it's sometimes hard for them to follow through. So we do maintain both the fully integrated behaviorist model, and then we also still have 2 full-time co-located therapists as well.
Okay, so just for summary for everyone, how many total behavioral health providers or staffing do you have in the practice?
So we have the 2 co-located therapists, and then we have 2 full-time integrated behaviorists, and we have the community support specialist, and then we have the coordinator.
Perfect, thank you.
Mm-hmm.
So as your primary care behaviorist model continues to evolve, because it sounds like you guys have had a lot of very positive evolution in your program, we would love to hear what's next for you and your team. So what are the next goals and tasks as they relate to behavioral health integration at Springfield Family Physicians?
So I think the thing that we're trying to focus on most right now is figuring out how to integrate behavioral health into the management of chronic health conditions that are not currently controlled. We don't have a great system yet for identifying patients who are, not managing their diabetes well and getting them involved with behavioral health, or people who are not controlling their hypertension, things like that. We're really trying to figure out how to kind of develop workflows and target those patients in order to get behavioral health providers involved. We've gotten very good at identifying mental health issues and bringing in the behaviorists for that, but I think our next step is really to focus on the unmanaged chronic health conditions. And as we do that, we will likely need to increase the number of behavioral health providers that we have. Currently, our providers are all fairly busy, and so just over time, I'm sure at some point we will need more behavioral health providers. And then lastly, just continuing to work on the increase in collaboration. I think ideally we would like to have a workspace that has the primary care and behavioral health providers all in one shared space. We have another clinic that has that model, and it seems to work really well in terms of collaboration. So I think for this clinic we would like to move toward that as well. And then also just an increase in shared care planning as well. It would be helpful for us to be able to get the behavioral health providers more involved in developing those shared care plans as well. And then also more sort of structured huddles where we can go through in a systematic way and discuss some of the higher risk patients.
Megan, this has been great. I really want to thank you for sharing your insight into how your team chose the primary care behaviorist model for your behavioral health integration initiative. Your tips for successful model integration are very helpful, and they serve to remind us that practice culture and that collaborative multidisciplinary team structure are certainly necessary to ensure both effective and efficient care delivery. So at this time, I'd like to move us to the Q&A portion of today's event. We love all the chatter that has been happening here, so let's see if we can address some of your questions. As a reminder, you can submit your questions via the chat pod. So at this time, I'd like to hand it over to Jennifer Boaz to share your questions.
Thanks, Stephanie. So we do have several questions coming in through the chat. And some of them are pretty similar to each other. So the first one is, how do you handle documentation, the counseling documentation within your EHR? Is the behavioral health documentation included with the medical documentation as well?
Yes, so our integrated behaviorists do document in the same record, and the primary care providers do have access to those notes. So it's definitely a different documentation style than would be in a traditional outpatient mental health program. And all of our behaviorists are trained to be, I guess, more careful about how they write their notes, knowing that they're going into the primary care record rather than a specialized mental health program.
So we did have a couple questions on kind of how you keep those therapy notes secure and privacy considerations. Will you maybe elaborate a little bit more on how you kind of trained your staff or how they might document differently since it is a shared record?
Yeah, so I think kind of the primary thing is just really only including the information within the notes that is necessary. And really, those behaviorists are really trying to triage what the needs of the patients are. So like I said, we do still have the co-located therapists that operate out of a completely separate health record. So if there are patients who have significant trauma or more significant mental health issues where it would be more appropriate for the documentation to be private, we will refer them either to one of our co-located therapists or we'll refer them out for specialty mental health services. So the integrated behaviorists are focusing on kind of less severe needs and really focusing more on sort of symptoms, managing anxiety, depression, those kinds of things. So they will document within the record, but really their documentation is focused on sort of symptoms, patient goals, and whatever follow-up is necessary.
Great, thanks, Megan. And we had one more question related to the communication piece and what's included in the communication between the primary care provider and the behaviorist. And since they're both charting in the same record, do they send any kind of, I'm going to ask this question a little bit different way, do they send any kind of notification? So if the patient comes in to just see the behaviorist, is there a way that the behaviorist will notify the primary care provider that the patient has been seen that day? Any kind of communication in that manner?
There often is communication in that manner as it is relevant to the primary care provider. So often if a patient comes in and the primary care provider is wanting to know, what the diagnosis is for a patient so that they can prescribe medication, the behaviorist will notify through the electronic health record or in person what the diagnosis was so that the primary care provider can prescribe medication. Or if there's other sort of significant changes in the patient, then the integrated behaviorist will notify the provider of whatever those changes are.
Very good. And we had one more question come in regarding the shared documentation. Do you notify the patients in any way or have a privacy policy or additional consent for that documentation to all be contained within one record and be accessible by the care team?
Yes, that is a conversation that's had with every patient when they come in for an initial visit with the behaviorist. They do let the patient know that all of the documentation is shared within the record. I guess another thing to note is that we're very careful when we release records, since it sounds like there are some concerns about the sharing of information. The people in our records department typically take behavioral health notes out unless they're specifically requested. So if we're sending records to somebody that doesn't need the behavioral health records, we won't send those out to people, to other organizations or individuals.
Very good. Yeah, I think there are a lot of people concerned about that privacy piece, understandably. So we did have several questions on that. So thank you for addressing it.
Sure.
We also have a couple questions around how you're billing for these services. Will you talk a little bit about how you're billing for the behavior services?
Yeah, so there's the primary coding that we use is either just typical therapy codes, so the 90832, 90834, 90837, depending on time length. So those are just traditional mental health billing codes, therapy codes. And then the other codes that we use are the health behavior codes. So if we are focusing primarily on a health condition, so if we're primarily talking to somebody about managing their diabetes and maybe how their mood is impacting that, then we will bill those health behavior codes, which are the 96150 series through 55.
Very good. And then we had another question come up. So if you build the general therapy codes, what do you do about prior authorizations if it's within primary care and not a specialty referral?
Sorry, can you ask that question again?
Yeah, you bet. So when you're billing the general therapy codes, what do you do about prior authorization if you're delivering those services in primary care and not a specialty referral?
So typically what we will do is if patients are wondering about their bill, or if they are, if they have questions about what their copay may be, we typically direct them to our billing department. I might not be able to answer these questions super well, but the billing department will often do sort of in advance that process. So whatever might be needed, if there are prior auths needed, they can do those because we typically will schedule the appointments in advance. It does get a little bit more complicated around the same-day visits and the warm handoffs, which often don't get paid, unfortunately, by insurance because they're on the same day, and some insurance companies don't allow that. So that is something that the clinic has sort of agreed that it's better for the patients, and so they're willing to write those costs off.
Great. Thank you, Megan. I know we always tend to have a lot of billing questions around this, and practices are always curious how others are doing the work. So thank you for sharing those details with us. And since we only have a couple minutes left, Stephanie, I'm going to hand it back over to you to wrap things up for us.
Thank you so much, Jennifer. So in addition to learning events, there are numerous resources that are available to assist you in your practice. Several are posted on CPC Plus Connect and are also listed here. Definitely be sure to check these out. We will also have these files and the recording available to post on CPC Connect soon. We definitely value your feedback. Our intent is to always keep improving these events, and your evaluation input helps us change and improve CPC Plus national events. The evaluation is being pushed out to your screens now and will take less than 2 minutes to complete. We hope that you will join us next week for Practices in Action that will focus on using data to steer care for your high-risk patients. And last but not least, I want to give a huge thank you to Megan Post for sharing their practice feedback and how they implemented the model and all of their lessons learned. And I want to thank all of you for taking the time to join us today. We hope you have a great rest of your day.